I think, John, I've come to see it as a broader thing than I'm about to tell you. But I'll just tell you what I think it at least is, and then maybe we can talk about the broader thing later. During the pandemic, there were two competing norms of conversation and discussion, public discussion. First, there's the norm of public health. In public health, there needs to be a unanimity of messaging, right? So, if I, as a Stanford medical school professor, come out and say smoking's good for you, I've committed a sin. I'm doing something really, really wrong. I'm going to convince people of something that is so clearly against the scientific evidence that will end up harming them if they believe me. Right? So there's an ethic of even academics need to be careful about how they speak about public health matters because the public is listening.
Okay.
And then on the other side, you have the norm, the ethic of academic freedom, of science, of free discussion. You need to have the ability to tell even, the top scientists that they're full of BS because they might be. The free exchange of ideas is absolutely central to the progress of science. And in principle, tenure is supposed to protect you against that. Now, more broadly, tenure sometimes doesn't do that. In fact, what it often does is there's this sort of I want to fit in more. I want to climb the social ladder even after I get tenure more. And if I criticize the high guy above me in the social ladder, I'm going to get kicked off the ladder. I'm going to be put down a rung or two, right? If I don't comply with what the NIH, the National Institute of Health, wants me to, the sort of the paradigm they want me to think when I apply for a grant, I won't get the grant, right? So there's some other mechanisms of social control within academics. But in principle, it should be possible to say to the world at large, this scientific idea is wrong, and here's what the implication is, and here's what an experiment shows that contradicts what the conventional wisdom is. That's how science advances. So you have two competing ethics in the middle of a pandemic. On the one hand, you have the ethic of public health messaging, which is unanimity, and on the other hand, you have the ethic of science and academics, which is freewheeling discussion. And they clashed during the pandemic. The problem is that the scientific basis for the ethical norm of unanimity of messaging, it has to be just an absolute unanimity of science behind it, right? There's very, very, very few people who legitimately, in fact, I don't know of any that would legitimately say that tobacco doesn't cause lung cancer, right? And so there's an ethical basis for the ethic of unanimity of messaging in that setting. But we have a pandemic when there's a tremendous amount of discussion, a tremendous amount of questioning about the policies and the science for a new virus that's come up out of, come up out of not nowhere, but, we can talk about that too. But the point is that, of course, we don't have unanimity in science because the science has just started to look at the thing. And so on what ethical basis could there be to say there must be unanimity of messaging in public health when you don't have the scientific basis for that?
So I want to read a little bit from the opening of the Great Barrington Declaration. I was tempted to read the whole thing for those that hadn't seen it, but I'm not going to do that. You should, we'll put a link to the Great Barrington Declaration in the comments. And then I want to come back, because to me, trying to understand who and how to trust medical expertise has become so damaged as a parent in particular. What should we do for ourselves and for our kids has gotten so scrambled in the aftermath of COVID that I don't know how we're going to recover. And I hope we'll spend a lot of our conversation talking about that. But first, so this was published in October of 2020, and it reads, just the first opening sort of declaration. As infectious disease epidemiologists and public health scientists, we have grave concerns about the damaging physical and mental health impacts of the prevailing COVID-19 policies and recommend an approach we call focused protection, in capital F, capital P. Coming from both the left and right and around the world, we have devoted our careers to protecting people. Current lockdown policies are producing devastating effects on short and long-term public health. The results, to name a few, and this was in October 2020, include lower childhood vaccination rates, worsening cardiovascular disease outcomes, fewer cancer screenings, and deteriorating mental health, leading to greater excess mortality in years to come. which I believe has played out, with the working class and younger members of society carrying the heaviest burden. Keeping students out of school is a grave injustice. Keeping these measures in place until a vaccine is available will cause irreparable damage, with the underprivileged disproportionately harmed. And what you go on to explain, and please correct me if I mischaracterize this in a summary, that as of October 2020 was that COVID-19 was essentially no more dangerous to our kids than influenza. In fact, it appeared to be less so. And that its primary risk factor was for people who were relatively old with severe pre-existing conditions. So if you were in your 70s or later, maybe you can push that down to 60s. But if you were basically of retirement age and had other conditions such as heart disease, diabetes, et cetera, you were at risk. And so what we should have done with our scarce resources is do everything we could to protect those people, including making sure that the medical professionals they might be interacting with have gained natural immunity through exposure to the virus, and basically let everyone else go about their life as usual. The kids should go to school, soccer games should continue, even basketball games indoors should continue. Basically, life should go on as normal. We should achieve herd immunity. We're going to get there anyway. Is that a fair characterization of what the proposal was?
Yes, that is a fair characterization. I mean, it's striking the way that you put it, John, because the way that people like Tony Fauci put it was he read the same thing you did and called it a let it rip proposal. But I don't see how that's a fair reading of that. What we were arguing was exactly what you said. How can we better protect older people? We'd already failed at that in October, right? We had sent COVID-infected patients into nursing homes. That happened around the world. If the principle of focused protection had been in place in March of 2020, no one would ever have thought to send COVID-infected patients to exactly the place where the most vulnerable people lived. Instead, the idea of was that we have to stop this disease from spreading by any means possible, even if we harm the poor, even if we harm children, even if we harm the working class. And that's exactly what we did. It was like trying to stick our finger in a dike and the water comes just, is pouring over it. It was a strategy doomed to fail in its own aims, which is to protect people against the disease. Tremendous numbers of older people died anyways. And it was almost tailor-made to harm the futures of our children, harm the futures of the poorest people around the world. There were estimates already by October 2020 that 130 million people were thrown into starvation as a consequence of the economic dislocations caused by the lockdowns worldwide. It was an immoral policy, and that's why we had the grave concerns we had, and that's why we wrote the declaration.
I want to just point out that you were not alone. You co-authored along with Dr. Martin Kulldorff, a professor of medicine from Harvard, and Dr. Sunetra Gupta, who is a professor of epidemiology from Oxford. So Harvard, Oxford, Stanford. You didn't lack for credentials. Now, I'm trying not to lose my mind as I recount these things. The thing that was so weird for me, it seemed like pretty quickly we knew that this thing wasn't as bad as it looked. I was revisiting my own Facebook posts, and as early as March, I was like, because we were all bored sitting at home and scared and reading all about this stuff, and I had sort of come across that it looks like what Sweden is appearing to do is probably what we should all do. But what was known then? Going into this thing, what was the state of the art in response to something like this? There had been SARS viruses in the past. Asia had suffered through multiple SARS pandemics. So what was the common knowledge in 2019 that did or didn't survive into 2020?
So the pandemic plans, the civilian pandemic plans, did not envision a lockdown of society at large. Nothing like what we did. The civilian plans emphasized local infection control, quarantining the unhealthy, maybe screening for fevers in high throughput areas and so on. That's how the first SARS pandemic was managed. Actually, I don't think if we'd done exactly that, I think we would have done much less harm. And I think the disease would have spread marginally more quickly, but I don't think a palpable difference would have been made in disease spread. The main thing that we knew in 2019 was we needed in the civilian plans was we needed something that was tailored to the specific epidemiology of the disease that was spreading, and also that was mindful of the fact that you have to allow people to live their life, or else if you disrupt it, you're going to cause more harm than good. Just from a health perspective, never mind the economy. That was my understanding of the civilian plans for public health management of a respiratory virus pandemic in 2019. When the pandemic hit, it was very clear from the earliest data that was coming out of China that there was a very steep age gradient in the risk of dying, where and it's exactly as you said, John, young people, children especially, were at a very low risk of dying if they got infected, again, from the very early days of the pandemic, lower than the flu. Whereas for older people, it was a much more deadly disease than the flu. Older meaning, and there's no like single age threshold where you say, okay, it's a risk for above and not a risk below. It's every 7 years of age, the risk doubles. So for 50-year-olds, in 2020, early 2020, if you got infected, the mortality rate was roughly 2 out of 1,000. If you were in your 80s, 90s, it could be 5, 6, 7, 8%. It could be a very, very significant death rate. If you were a child, it was 1 in a million. So you had this very, very distinct age-related gradient in risk, and that was known in December of 2019. I first saw those data, I think, in like late January 2020. And so I knew for certain. Martin Kulldorff tried to publish a piece in early February 2020 where he wrote up this age gradient and couldn't find a publisher for it. He ended up putting on his LinkedIn blog. This is a Harvard statistics professor, epidemiology professor. And so that was known very early. What wasn't known in March of 2020, I think, was two things. One, how widespread was the disease already? How effective had been the infection control measures that had already been taken in stopping the disease from spreading? And two, what was the average infection fatality rate? So I wrote an op-ed in March of 2020 in the Wall Street Journal. It's the first time in my life I ever wrote an op-ed. I used to just write scientific papers for a living. And the op-ed said, we don't know the answer to these two questions. And it's critical, right? Because if we're in the middle of locking down the entire world, causing untold economic harm and catastrophic damage, public health damage to the poor, we close schools, which was certainly going to harm the future of our children. Was there any real warrant for it, even leaving aside the harms of the lockdowns? If the disease had already spread everywhere, had been seeded everywhere, then what was the purpose of the lockdown? If the disease had a low average infection fatality rate, it would then what we needed to do was focus on the people that are highest risk, the older population, and protect them. And so I wrote this op-ed. That led to my actually running a study measuring how many people had antibodies to the virus in April of 2020.
Okay.
In Santa Clara County, California, and then Southern California and LA, we found the same answer. Roughly 3 or 4% of the population already had the virus, which doesn't sound like a lot, but actually we'd just been in a lockdown for a month and some, and there'd been there's no from first glance, it didn't seem to have stopped the disease from spreading, which is now not surprising given we know it spreads by aerosols and it spread very easily. And then two, the disease, the infection fatality rate was 2 out of 1,000 overall in the population. That's the number we got. A whole bunch of studies came after us with independent research teams from around the world that replicated that result. Ours was right smack dab, almost in the middle of all of the other studies that have looked at this. The disease had already spread, and there were, for every person who had been identified as a case, there were 50 people or 40 or 50 people walking around Santa Clara County, California, or LA County, California, who had antibodies that public health knew nothing about.
Okay,
it really was like sticking your finger in a dike, right? We were like, oh, we've stopped the water coming out of that hole when the water was spreading around all around us.
If you like this clip, you should check out the full video and all the other great content we've got at Dad Saves America. So be sure to hit the like button, subscribe, and ring that bell so you won't miss our new stuff as it drops each week.